Today's lecture is about the rheumatology. This lecture is suitable for those people who are either going to start their PLAB 1 preparation or who are done with their preparation and before the exam they are going to revise. Well, nevertheless, you can go through this exam anytime in between, but particularly for those people who are going to start or who are going for the revision. Okay, so starting from the autoantibodies, okay, SLE. So SLE has anti-dsDNA antibodies. Okay, these are 99% specific and 70% sensitive anti-dsDNA. The other antibodies that are present in SLE, those are anti-SMN antibodies. They are 99% specific but less sensitive as compared to the dsDNA, which is 70% sensitive, but these SM antibodies are 30% sensitive. So whenever you have to choose between the two, you need to choose anti-dsDNA. 99% of the patients in SLE, they have ANA antibodies, but like ANA are not specific. They are there in most of the rheumatological disease, autoimmune diseases. Sometimes they just change the options. There are no anti-dsDNA, there are no SM, but there is ANA. In that case, you need to choose the ANA over here. The next thing is drug-induced lupus. So antihistone antibodies are positive. Your MCQs are going to be like this. Okay, that if somebody is having a drug-induced lupus, which antibodies will be positive? Some straight questions will be over there. The difference between the SLE and the drug-induced lupus is that in the drug-induced lupus, it doesn't has the glomerulonephritis. The patient do not have the glomerulonephritis. In SLE, there is glomerulonephritis. And which glomerulonephritis is most common? That could be one of the MCQs. That is diffuse proliferative glomerulonephritis. And what you give? Initially the steroids and then the mycophenolate. Okay. Then comes the systemic sclerosis and diffuse scleroderma. Diffuse scleroderma. There's limited and there's a diffuse scleroderma. So in the diffuse scleroderma, there are anti-CL70 antibodies. The other name for anti-CL70, you need to remember that is topoisomerase 1. Topoisomerase 1. So you need to remember that one. For the limited scleroderma, you have anti-centromere antibodies. Anti-centromere antibodies. Okay. So for polymyositis, you have anti-Jo1 antibodies. For dermatomyositis, there are anti-MI2 antibodies. Okay, these anti-centromere antibodies, the second name for them is anti-synthetase antibodies. So you need to remember that one. Sometimes there is no anti-Jo1, there is anti-synthetase. You need to go for that. And sometimes there is no anti-SCL70 in case of scleroderma. So there is topoisomerase 1 antibody. So you need to choose that one. You need to remember this thing. Okay. Then is the Sjogren syndrome. There's anti-Rho and anti-LA antibodies. These anti-Rho and anti-Rho particularly is there in, you need to check that one in a patient who is SLE and who is pregnant, because they are linked with the heart blocks in the neonates actually. Those ladies who are having the SLE, and they are pregnant, you need to check for anti-Rho antibody. If they're positive, the child, okay, the neonate, has chances of having the heart blocks. So you check that one. So anti-Rho you need to remember as far as Sjogren syndrome is concerned, and also for the SLE, a pregnant lady with SLE. For primary biliary cirrhosis, anti-mitochondrial antibodies, that is AMA. For autoimmune antibodies, autoimmune hepatitis, that's anti-smooth muscle antibodies. You need to remember these things, okay? They are all like that, and sometimes we are a little bit confused in this thing because there are so many antibodies. You need to remember those, okay? Let's go next. Okay, there are some other, like in Sjogren syndrome, that's PNK. In vaginal granulomatosis, there's CNK. Okay, in the celiac disease, okay, if you have to choose one, that is anti-tissue transglutaminase out of all these. Okay, do not choose anti-gladin or anti-endometrial antibodies. Choose the anti-tissue transglutaminase. Okay, then Graves' disease, yeah, you know that in the Graves' disease, there are TSH receptor antibodies, the other is thyroid peroxidase antibodies, but choose TSH receptor in the graves if it's there. Then in the rheumatoid arthritis, you know that it's a rheumatic factor, that is, and anti-CCP antibodies. Now let's come to the SLE. So SLE is actually a multi-system, multi-organ disease, okay, I should say. So you have the involvement of the multiple organs. Okay, there is starting from generally there's a fatigue, fever, there are mouth ulcers. Okay, it can involve your skin. You have mallow rash. Okay, that's called butterfly rash, discoid rash, photosensitivity, Raynaud is there. Then arthritis is there. Then it could be pericarditis, pleuritis. There could be renal involvement. There can be hematological involvement, hemolytic anemias, leukopenia, or thrombocytopenia. Okay, so there could be the neurological involvement like seizures and psychosis as well. So it's a multi-system, multi-organ disease. Okay, that's of the autoimmune etiology. So here you can see, yeah, it has clearly mentioned over here. So you have CNS involvement, you have cardiac, you have respiratory involvement, you have joint involvement, skin is involved over there, kidneys are involved over there. Okay, so many things over there in SLE. Okay, so AN is positive in SLE. As I have already said, 99% sensitive. Anti-DS2NA, that is highly specific, 99%, and 70% sensitive. The other thing is I said anti-SM antibodies. Maybe there's no NA, there's no anti-DS2NA. So choose the anti-SM, that is 99% specific and 30% sensitive. Complement level is decreased. Okay, so antihistone is only in drug-induced lupus. Okay, we're going to discuss the drug-induced lupus. Okay, let's discuss it over here. The drugs which can cause the drug-induced lupus that are hydralazine, isoniazid, procainamide, and quinidine. Okay, the difference is that here there's no kidney involvement, and once you stop the drug, the effect's gonna go away. Okay, and anti-DS2NA, that is negative in drug-induced lupus. Okay, and also the low level of complement, it's rarely seen in drug-induced lupus. So the difference between the SLE and the drug-induced lupus is that, let me summarize that one again, that the drug-induced lupus, there is no kidney involvement, and once you stop the drug, it's going to go away. Anti-DS2NA is mostly negative, and this hypocomplementemia, that is decreased complement level in the C3 and C4 in the SLE, that's not over there. The drugs involve hydralazine, procainamide, and quinidine, and isoniazid, of course. If you talk about the HLA association, DR3 and DR4 association is there. Mostly it is in the females for SLE. The female to male ratio is 9:1, and the age group is it's more common in between 20 to 40 age bracket in the females. Okay, there are the other important things you need to remember, that you check the ESR and anti-DS2NA for the disease activity in SLE. CRP is normally it's normally not raised in the SLE. If it is raised significantly, you might consider other things like infection. Okay, that was about the SLE. So what you give, there are not much treatment options available. You give for the skin, for the arthralgia, you give the hydroxychloroquine, that is HCQ. Then for arthralgia, you can give the NSAIDs. In flares, you can go for the prednisolone. Okay, and if there is a kidney involvement, go for mycophenolate, okay, rather than cyclophosphamide. Cyclophosphamide is a second line. Choose mycophenolate if it's over there. Okay. There are certain other things as well which I would like to discuss over here, is that fertility rates are normal in patients with SLE, okay, but spontaneous abortions and the stillbirths, they are more common as compared to the normal people. So SLE doesn't affect the fertility, and there is something other that is linked with SLE, that is antiphospholipid antibody syndrome. Okay, so you need to check for that in those patients who are having the SLE coming with the recurrent abortions, particularly the first and the second trimester abortions. And when a lady is pregnant with SLE, you need to check for anti-RO, that is RO, and anti-LA antibodies, because those ladies, okay, the neonates, that causes the heart blocks in the neonates. Then the drug-induced lupus, I have already said much about that. The hydralazine, isoniazid, procainamide, and quinidine. Okay, and I have already told you the differences. This is a little bit more about, okay, the questions which they are going to ask. Which one is more sensitive? ANA is most sensitive. Okay, what's the initial test? ANA is the initial test you need to go for. What is the best screening test? ANA. Okay, now in the new criteria, they have put the thing over in the SLE diagnosis that check for the ANA, because the 99% specific sensitive story need to be positive. If that's not positive, ANA must be positive, okay, for the SLE. So they have included in the criteria that if you are suspecting an SLE in some patient, so go for the ANA. If it's positive, then go for the further things. So what is most specific? That is anti-DSTNA. Most discriminative? That is anti-DSTNA. There is other thing, that is anti-Smith antibodies, that is equally specific as compared to the anti-DSTNA, but that is less sensitive. So you need to choose for the anti-DSTNA. Okay, the next thing comes here is chronic fatigue syndrome. Okay, what is chronic fatigue syndrome, by the way? So in the chronic fatigue syndrome is when somebody is having a 4 month of disabling fatigue. Okay, 4 month period. Okay, you have a disabling fatigue, and that's present for the 4 months. These people, they have sleep disturbance, they have muscle, joint aches, sore throat, headaches, okay, and they have tender lymph nodes which are not swollen, okay, which are not swollen, but they are painful, okay. Then they have cognitive dysfunctions, dizziness, palpitations, and one very thing is that any of the physical exertions that worsen their symptoms, okay. You can remember something like that, a chronic fatigue syndrome, a 4 month of fatigue in a patient, okay, having sleep disturbance, having aches and pains, okay, having swollen, not the swollen, okay, just painful lymph nodes. They are normal in size, but they are painful. And all these things put together, that's going to disturb your cognitive function. You cannot concentrate, okay, you cannot, and any of the exertion these patients make, that worsen their symptoms. So what you're going to do? The treatment is CBT, first line. The second thing is graded exercises, okay? Like they don't need to exert much, okay? They need to keep pacing, like graded exercises. Gradually, they need to build their activity. The other thing is pacing, okay? And in some of the patients, if these things are not working, you can give low dose amitriptyline, that is tricyclic antidepressants. So that was about the chronic fatigue syndrome. Okay, now comes the polymyositis. So what is polymyositis? So something you can like guess from the name itself, it implies itself, that is related to the muscles. Okay, so polymyositis. So this is actually an inflammatory myopathy. Okay, there's also an inflammation of the muscle, and it presents with the progressive muscle weakness. Okay, the one thing is polymyositis and the other thing is dermatomyositis. Difference is in the dermatomyositis, there is a muscle weakness, but there is the skin involvement as well. In dermatomyositis, as the name implies, that the dermatomyositis, derma, skin, and myositis means muscles, okay, that are involved. So let me repeat that these are inflammatory myopathies, both in which there's a progressive muscle weakness. In polymyositis, there's just muscle involvement. In dermatomyositis, there is muscle involvement as well as there is skin involvement as well. Okay. So polymyositis is symmetrical and diffuse muscle weakness, proximal, greater than distal. So have difficulty rising from the low chair, climbing steps, lifting objects, and combing hair. Yeah. Well, the difference between the polymyositis, dermatomyositis with the other myopathies like Erythematosus syndrome or myasthenia gravis is that ocular muscles are never involved in polymyositis or dermatomyositis. Okay, so that is a feature that differentiates. You know, some myasthenia gravis, there is ptosis. Okay, there is involvement of there's dysphagia, there's dysphonia. Ocular muscles, okay, the ptosis, that's not there in these inflammatory myopathies, but that's over there in myasthenia gravis as well as in Erythematosus syndrome. Polymyositis is just the progressive muscle weakness. In dermatomyositis, there's a skin involvement, like helicotrophic rash. That's a purple discoloration of the face, eyelid, and sun exposed area, and there are something that's Groton papules. I believe you might have heard of this thing. These are the scaly lesions seen sometime over the knuckles. Okay, that is the dorsal aspect of your phalangeal joints, especially the metacarpopharyngeal joints. Okay, so let's come to the polymyositis. What are the investigations? The CPK is raised over. Okay, that's significantly raised, sometimes up to 54. Okay. In polymyositis, anti-Jo1 antibodies, these are raised, and the other name for anti-Jo is antisynthetase antibodies. Okay, antisynthetase antibodies. Increase LDH and aldolase. Yeah, yes, you do the electromyography as well, and you go for the muscle biopsy. That is the most definitive thing. Okay, so CPK, the antibodies, anti-Jo1. For the polymyositis, and anti-MI2 for dermatomyositis, and you do the EMG and the muscle biopsy. That is more specific. In dermatomyositis, there is a muscle involvement. There is a skin involvement, as I said, and dermatomyositis, that is also linked with the risk of developing the cancers. Okay, they have the risk of developing the cancers. Those people who are having a dermatomyositis, like ovarian cancer. So anyone who is coming with the dermatomyositis, you need to screen for these cancers as well. Okay, so what's going to be the treatment? Steroids. Okay, steroids are useful in polymyositis as well as dermatomyositis. Okay, sometimes you give the intravenous immunoglobulins in dermatomyositis. Okay, and other things like bed rest and some physiotherapy that might be helpful. So how are you going to follow the disease activity? Okay, in polymyositis or dermatomyositis, it's by the two things. It's by the clinical assessment of muscle power and by the CPK, that is creatine phosphokinase. Okay, so that's all about the polymyositis and the dermatomyositis. Also, we have done the dermatomyositis as well, so you can have a look over that. Helicotrophic rash, creatine papules, Scholl sign is over there, a rash around the neck. Okay, so skin involvement, dermatomyositis. You can see the creatine papules over here. Okay, the things remain the same for the treatment options as well as the diagnosis, the labs. They remain the same, but yes, in dermatomyositis there is skin involvement. Okay, the next topic is Polymyalgia rheumatica. The scenario will be an old lady, okay, that is coming to you with the pain, okay, in shoulders and in the pelvic girdle. Okay, is a difficulty in getting out of the bed and raising the arms. Okay, so this would be the history of an old lady that is coming to you with the pain in the pelvic girdle as well as the pain in the shoulder. Okay, so this is the polymyalgia rheumatica. Okay, and this is associated with temporal arthritis or joint cell arthritis. Okay, so always somebody is coming to you with the polymyalgia rheumatica, you need to screen that one for temporal arthritis. Any problem with the vein, you need to ask shock claudication and all that sort of things which are present in the temporal arthritis. Okay, so ESR would be raised. That is the most important thing. You need to remember if somebody's ESR is raised. okay, and they have normal creatine kinase, and treatment is steroid, okay. The moment you're going to put the patient on the steroid, okay, their symptoms become better and the ear sore, okay, comes down. Okay, so that's the thing. So remember with the P, but it says polymyalgia, the pain, but not the weakness. So muscles are tender. That's not true weakness. Okay, that's fine. Enough in polymyalgia. Okay, you need to remember, okay, some lady particularly over the 50 coming to you with a pain in the shoulder and pain in the pelvic girdle. You go for the ESR, that is, you put on the steroids. Okay, CPK is normal over there. That's all about which I have already told you. And then the topic comes, that's the temporal arthritis. That's the problem with the medium to large vessels. Okay, these people, they come with a headache, jaw claudication, okay, scalp tenderness, visual field problem. That is the most serious thing over here. And that is associated with the polymyalgia rheumatica. That is the most important thing to remember over here. Okay, they have raised ESR. The definitive is temporal artery biopsy. Well, is that always going to give you something? No. Temporal, they have skip lesions. Okay, maybe you are going to take that portion of the biopsy where there's nothing. So even if the patient is presenting with the symptoms, and if it's saying, okay, you are very much sure that it's a temporal arthritis, jaw claudication, the problem with the headache, it's a tender scalp, they have the problem with the VN, the biopsy is normal. Still, it could be joint cell arthritis because as there are the skip lesions, there's no continuous thing over there. So biopsy might have been taken from where it was normal. So it's not that biopsy is going to be always positive over here. Treatment is high dose steroids. Okay, high dose steroids to prevent the permanent loss of VN. When there's a eye involvement, give IV steroids. Otherwise, like, you can give the oral steroids, no problem at all. Well, the role of the aspirin, literally, it's controversial. Okay, some of the researchers, they say that, okay, you can give the aspirin. Some do support, some do not support. The role is controversial. Okay, this is joint cell arthritis. Okay, let's see this one. Patient with a headache and scalp tenderness, typical. Jaw pain, presents to emergency department. What is appropriate management? Steroids. Don't delay the steroid. Okay, don't delay the steroid because there is a risk of losing the VN. So start the steroids. Okay. Okay. Now comes Sjogren syndrome. Okay, let's go to the Sjogren syndrome. So that's an autoimmune disease of the exocrine glands. Actually, it is characterized by the lymphocytic infiltration of exocrine glands, resulting in xerostomia and dry eyes. Okay, and yeah. So there's an enlargement of parotid and lacrimal glands, dry eyes, dry mouths associated with rheumatoid and SLE and scleroderma. So what kinds of tests we're going to do in Sjogren syndrome? So it's a Schremer test that will show decreased tear production. The other is Rose Bengal stain will document the corneal ulceration because they have dry cornea. So ANA will be positive, and the more like specific or anti-Rho and anti-LA antibodies. Okay, the RF is positive, ANA is positive. Okay, so lymphocytic infiltration of the salivary gland will be noted on the biopsy as well if you're going to take the biopsy. Treatment includes artificial tears and plenty of water, nothing else. Okay. Sometimes pilocarpine is also used, that increases the acetylcholine and increases the tear and the saliva production. There's no specific cure for the Sjogren syndrome. Okay. But lifespan is normal in these patients. Evaluate these patients for the lymphoma. This is something you need to remember. Okay. Evaluate these patients, okay, for the lymphoma because they have a tendency of developing the lymphomas. That is about the Sjogren syndrome. Okay, so next is hypermelosis. That's a type of eye drop to help treat the dry eyes. Oh, well, that's not important. Now comes another important thing, that is systemic sclerosis. Another very important topic. So they have actually the two things. There are many types actually, believe me. But at your level, just be limited to it. Limited and the diffuse. Okay. In the limited, this crest is actually a subtype of limited. Okay. Limited is actually where there is the skin involvement is not extensive. Okay. And the organ involvement is less. Like if it started from your fingers, then it's gonna go up to your elbow and not beyond that. If you started from the foot, it should go up to your knee and not beyond that. Okay, that is limited scleroderma. And in the diffuse, that's a rapid onset, involves the trunks and the lymphs and go upward. Okay, so actually this is a chronic multi-system disease. Okay, that is characterized by thickening of the skin. There is accumulation of connective tissue and involvement of the visceral organs like GI and the kidney. Raynaud phenomena. All the patients have the Raynaud phenomena and the skin thickening almost. Okay. In limited, you need to remember that one by crest. That's calcinosis, Raynaud, esophageal dysmotility, scleroductal, and telangiectasias. Pulmonary involvement is actually the most leading cause of death in patients who are having the scleroderma. Okay, actually, there is systemic sclerosis and there is localized scleroderma. Okay, and there are 2-3 types in the localized scleroderma, and the systemic sclerosis has limited cutaneous and limited crest. But you need not to go into that detail. Just remember that one. There's a limited and there is a diffuse. And the limited, there is a crest. And in the diffuse, there is extensive involvement, okay, of the skin as well as internal organs. So if we talk about the antibodies over here, anti-CL70, they are positive over here. Anti-CL70 in diffuse, while in limited, there are anti-centromere antibodies. Those are positive. Okay, and the other name for anti-CL70, I already told you what was that. The other name for anti-CL70 was, that was topoisomerase 1. Okay, anti-CL70. That was anti-topoisomerase 1 antibodies. That are in the diffuse, and anti-centromere antibodies that are there in limited scleroderma. Okay. So now comes the seronegative spondyloarthropathies. Okay, there are like 3-4 things over there: psoriatic and ankylosing spondylitis, arthritis syndrome, Behçet's IBD-associated arthritis. Okay, there are some specific features which are there in these seronegative spondyloarthropathies. Which are those? Let me tell you. They are ANA negative and RF negative, rheumatoid factor negative. Okay, they involve the lower back and the sacroiliac joints. They have HLA-B27 association, and they have extra articular manifestations. These seronegative, that's why we say, because ANA negative, they are RF negative. Okay, and these 4 features are over there. Most of them have these 4 features that are ANA negative, RF negative, involve the lower back and the sacroiliac joint, HLA-B27 association, and extra articular manifestation is over there. So let's discuss Behçet disease. Okay, these are somebody's coming to you with the oral and the genital ulcer. Okay, you need to consider the Behçet disease. Anterior and posterior uveitis and pathology, that is exaggerated skin injury after the minor trauma. So what you need to go going to need to go for the topical steroids. The other very important thing that is ankylosing spondylitis in the seronegative. So it's a young guy who is presenting with the lower back pain to you. Okay, he has a chronic lower back pain. Okay, in early 20s or 30s. So the patient will be coming to you with a morning stiffness that is lasting at least for 1 hour and improves with the exercise. A young guy is in the 20s and 30s coming with a chronic lower back pain that is there in the morning and that alleviates with some kind of activity. Okay, these patients with the ankylosing spondylitis, they can have some extra-articular manifestation. Okay, like all the A's you need to remember: anterior uveitis, aortic insufficiency. Okay, AV blocks. Okay, they are there in these patients. Okay, so what treatment you're gonna go? What is the examination findings? Okay, there's a positive Sjogren test. There will be over there. There's decreased spine mobility. Okay, sometimes there's lumbar lordosis as well. X-ray is gonna show you the sacroiliitis. You need to remember this thing. Okay, what is there in the X-ray? Sacroiliitis. Okay, sacroiliitis. The other things on the X-ray could be squaring of lumbar vertebra. Squaring of the lumbar vertebra. There's a bamboo spine. You can see over here. There's a bamboo spine. Squaring of lumbar vertebra is over there. Okay, and syndesmophytes. Okay, that is abnormality of the spinal column. Okay, this vertebral that's characterized by calcification and ossification of interspinous ligaments. Okay, and that's appears as a continuous line. You can see it over here as well. Okay, the spinous process, they are appearing as a continuous line because of the calcification. Okay, giving a tram-line appearance. Okay, so on the X-ray, you need to remember there's a sacroiliitis, fusion of sacroiliac joint, squaring of vertebral bodies, and bamboo spine. Yeah. So what are the treatment options over here? Okay, NSAIDs. Okay, there are physiotherapies, there are exercises there. Okay, and these TNFs, adalimumab and etanercept. Okay, they are there. Unlike rheumatoid, anti-TNF medications are used first. Okay, before the methotrexate, and particularly they are good for the axial skeletal involvement. Okay, not good for the peripheral but axial skeletal. They work better for the axial disease. Okay, in rheumatoid arthritis, we're going to discuss that one in a couple of minutes. You give the methotrexate first, and then if that's not working, you either go towards or you add the anti-TNF, okay, and the monoclonal antibodies. Here, give the NSAID and all that sort of stuff. If that works, okay, then you go for anti-TNF rather than methotrexate. So this is a disease of the young people, particularly the young males. The next thing comes is Reiter syndrome or reactive arthritis. Okay, so a mnemonic for that is, okay, which most of the people use is can't see, can't pee, can't climb a tree. Actually, that's a triad of urethritis, conjunctivitis, and arthritis. Okay, that is the Reiter syndrome or the reactive arthritis. Okay, so it's actually occurs as a complication from an infection somewhere in the body. Okay, either most common is actually the Campylobacter. Okay, it happens after a diarrhea, infectious diarrhea that's called by Campylobacter. Could happen actually after non-gonococcal urethritis, like from the chlamydia. So there could be either from a diarrhea that is because of the chlamydia, or a urethritis that is because of chlamydia, that is non-gonococcal arthritis. So it's a triad, as I said: conjunctivitis, urethritis, and the arthritis. Could be post-diarrhea, could be post-STI, that is sexually transmitted infection. Post-STI is more common in men, actually, and post-dysentery, that is because of Campylobacter, that is equal in both male and the female. Okay, the incidences. So diagnosis is based on this clinical criteria, and the X-ray findings are there. Okay, As this is seronegative, so you know that ANA will be negative, RF will gonna be negative. There will be HLA-B27 association. Okay, treatment is actually analgesia and NSAIDs. Okay, it really lasts more than 12 months. Okay, you have to give sometimes the other things as well. Okay, like the AS. Okay, you give sometimes sulfasalazine, methotrexate in these patients. Okay, there are one or two other things that are the complications from the infection, reactive arthritis, that is Scleroderma, melanohemorrhagicum, and succinate balanitis. Okay, what is Scleroderma hemorrhagicum? That is a cutaneous manifestation of arthritis syndrome. Actually involves the soles and the palms, toes, and the glass penis, as characterized by erythematous macules. Actually, they form the blister, and later they develop in thick keratotic covering. And the succinate balanitis, that's a shallow callus ulcer with gray borders that is seen on the glass in some patients with rheumatoid. That's not going to be in every patient. Is Scleroderma, melanohemorrhagicum, succinate balanitis, but you need to remember this. Yeah, that's there in some patients with the arthritis syndrome or the reactive arthritis. Okay, let's go towards the gout. Okay, another interesting, important topic, that is gout. Okay, important one. Okay, so what is gout actually? Okay, so this is actually the arthropathy, in which the monosodium urate crystals, okay, they tend to accumulate in your joints, in your synovial fluid. Okay, that is gout. Most of the times your first big toe that is involved, the second joint that is involved most commonly, that could be ankle, and sometimes the knee joint is also involved. Okay, that is gout. So there are the certain things which are associated with the gout, like which cause gout, like meat and alcohol, tumor lysis syndrome. Okay, sometimes someone who is taking the chemotherapy, particularly chronic kidney disease, those who are taking the thiazide diuretics, or some of the ACE inhibitors as well, less likely, but yeah, thiazide diuretics. It most commonly involve, as I said, the first tarsopharyngeal joint. How are you going to diagnose this patient? Okay, and that is by the joint aspiration. Okay, there you're going to see the monosodium urate crystals that are negatively bifringent. Okay, you need to remember this thing: negatively bifringent monosodium urate crystals. Okay, that you're going to see again a patient with the gout. And what test you're going to choose? Okay, that is needle aspiration. Okay, that is needle aspiration. So those are, again, I'm going to repeat, monosodium urate crystals that are needle shaped, negatively bifringent. Okay, on X-ray you can see the things like punched out lesions, but they are not present in the first attack. After the repeated attacks, there will be the punched out lesions on the X-ray. Okay, so now coming to the treatment. The treatment is NSAID or colchicine. That's the first line. Whenever the patient is having this attack, there will be the hot swollen first metacarpopharyngeal joint. That's tender. Okay, even if you do not treat that one, that's going to go away in 7-8 days. Okay, but the treatment is either NSAID or colchicine combined with the PPI. Okay, so if there's an option that's combined with the PPI, choose that one rather than choosing simply an NSAID or a colchicine. So if that's not there, okay, NSAID or colchicine, any of them you can choose. But if it's a combined option, there's an NSAID plus PPI, choose that one. Okay, so NSAID or the colchicine, and steroids in some cases, okay, if they are not working. So colchicine actually inhibits the microtubules polymerization and also inhibits the neutrophilic activity. It has a slower onset than the NSAIDs. Okay, Very important thing, okay, maybe that's they're gonna ask you this thing is that you need to decrease the dose of colchicine when the GFR is between 10 to 50, okay, and if it's less than 10, okay, maybe they are going to give you, okay, the patient with the CKD having a GFR of less than 10, avoid this. That's contraindicated actually below 10, okay. Consider oral steroids if this NSAID or colchicine are contraindicated or if they are not working, okay, and don't start a patient on urate-lowering therapy, okay, if febuxostate or allopurinol that are xanthine oxidase inhibitors, do not give, okay, during an attack. Once this attack subsides, then you can start on these urate-lowering therapies. There is another important point is that if patient is already taking allopurinol, okay, that is a urate-lowering drug, and he has an attack now, there you can continue the allopurinol, okay, but you cannot start somebody because that's going to end up in flare, okay. So allopurinol is first line, okay, but once this acute attack subsides, okay, you give the NSAID or colchicine with the PPI in this acute attack, and after 7-8 days, okay, once it's gone, then you can start on the allopurinol, okay. That's the first line. The second line is febuxostate, okay. Both allopurinol and febuxostate are xanthine oxidase inhibitor. In refractory cases, you can use uricase. Uricase is actually a drug that converts this uric acid to allantoin, and okay, you can get rid of, okay, the uric acid. In refractory cases, uricase, okay, you need to remember. In persistent symptoms, despite these urate-lowering therapies, pegloticase is infusion every 2 weekly. That is enough, an option. Well, there are certain general things, okay, like vitamin C, it decreases the uric acid in your body. The other thing is if somebody is taking these all ACE inhibitors, they actually build up the uric acid in your blood, okay. But one of them, that is losartan, you can remember that one from low means it lowers the uric acid. So somebody is taking the valsartan, sometimes the question is like this, and there's nothing other thing but so valsartan over there, what you're gonna do, so switch valsartan to losartan, okay. So yeah, these are all the things about the gout. I believe I haven't left anything that is important. Okay, another important thing is that when you're gonna start the prophylaxis, okay. So new guidelines say that offer urate-lowering therapy after the first attack even, okay. But there are like certain things where it is recommended, particularly if there are like greater than two attacks in a year, this tophi, or there are urate stones, or if somebody is taking a cytotoxic drug on the chemotherapy, okay. Yeah, you need to give those people the urate lowering therapy.